So, everyone, welcome to our sixth meeting of our 2021 virtual meeting series. And thank you all for being here. And tonight, not only is Dawn Laney my co-host, but she is also the speaker tonight. And she's speaking about females with Fabry disease. And so, being among all the things she does, having a large clinic at Emory and all of the other ways that she connects with females with Fabry, she has a great deal of experience in the things that are both common with females and males and unique to females, which there are a lot of things that are unique to females. So let me start by introducing Dawn once again. And so, why do I never have anything that I thought I had in front of me when we actually start? Oh, it's a characteristic of mine. I have it 1 second and not the next. Okay. So Dawn is she has a master's degree and she's a certified genetic counselor. She is a assistant professor, clinical researcher, program leader of the Lysosomal Storage Disease Center at Emory, as well as the director of the Genetic Clinical Trial Center at Emory University. He has, of course, as you would expect, Dawn's interest in both research and clinical work. Clinical work is about Fabry disease, so she spends most of her life thinking about us, and we appreciate that. Dawn does so much good in our community. She is also the co-founder of Think Genetic, and you can read her bio on the bios and page on the bio and speaker tab in the registration website. And Dawn also is the author of several children's books and has done so many more things than that short list, especially in either the lead or participant in many clinical or not clinical trials, but research papers. And so we always thank Dawn for being with us and sharing what she has, what she can tell us about females and Fabry disease. And I thank you, Dawn.
Sure. Thank you, Jerry. You guys, I'm so excited to talk with you today about, I'll start off with some basics in Fabry disease, and then we'll focus really on, some myths about women in Fabry disease, and then we'll talk about some of the research that's come out recently. But then I also want to hear from you. So there'll come a point where I'm like, everybody unmute, let's talk about these things, and you tell me what you're thinking. I do have some slides. Let's start with the slides, and we'll go from there. Okay, so one of the things that's really important to me is there are a lot of myths and a lot of areas where healthcare providers need to learn more about Fabry disease. And I think the problem is that leaves the burden on women with Fabry disease. They end up advocating for themselves a lot in ways that can feel really frustrating. And I want to just acknowledge that when it comes to living with Fabry disease as a woman, you guys are the true experts, and I'm just going to kind of put things together so we're all on the same page and we're thinking about Fabry disease in women from a perspective that makes sense, and also to help empower you a bit too, right? Here's my disclosures. As Jerry said, I do a lot of research. I'm involved in a lot of things in the Fabry space and also with Think Genetic. So you can see here that I do get some honoraria, do some consulting about everything from biomarkers to women in Fabry disease and gene therapy. So you can see those here. I'm a genetic counselor, and sometimes people don't know what genetic counselors are, so I like to add this in. To me, genetic counselors were like genetic superheroes because we like swoop in whenever there's a genetic issue going on, whether it's somebody has a new diagnosis or somebody wants to get tested or somebody wants to understand better about a genetic condition or about a treatment for it, and we try to give them the best information possible at the time. You'll see some of the myths we're going to talk about in my lecture today are they come from not having enough information or not understanding the information we have, and then learning more things as we go through life. And I think one of the great things about being a genetic counselor is I consider most of us lifelong learners. We like to get new information all the time. We like to learn about new things, and we like to challenge some of the old assumptions we have. So I was very fortunate to come into the Fabry disease world when we already knew women had symptoms. So I was right there on the cusp where it really became obvious. And there were some great publications that said, look, women have symptoms. I understand in the past we weren't thinking about things that way. But I came in and never had to like go back to everybody and say, oh, sorry, I thought you didn't have symptoms, but you do. But I have great empathy for those who were in that position. But I think that we've come to the point, it's been 20 years now, that we can just all accept that women have Fabry disease. So here's the plan I already spoke with you about. Okay, so the first myth that I was alluding to is that this bad word that keeps popping up, Fabry disease, which is carriers. Every time I hear carrier as it relates to Fabry disease, it's like fingernails on a chalkboard for me, and I bet it is for you guys too, because carrier goes with unaffected. And in my clinic, it is the exception for a woman to have minimal symptoms. Most women that we work with, take care of, hear from, have life-impacting symptoms. So for me, calling someone a carrier is kind of like cussing them out in my world. So, talking, lecturing. Sorry, small child who's not so small anymore. So let's talk about who is a woman with Fabry disease and what does it mean from just like a definition perspective? And why did this myth come about that women didn't have symptoms? Well, women having Fabry disease means that you've got a change, a mutation, or what we now call a pathogenic variant in the GLA gene, just one. Because women have two X's, and you just need that change in one of your X's to have the implications on your body. Now, women are complicated, as we well know. So every woman is going to have different symptoms, and some women may certainly be more affected than others. But we always have to check people out and not assume that they do or don't have symptoms. We need to look everybody as an individual. And the first thing we need to do for a woman is individually get them understand if they meet that definition of having Fabry disease. And we can't do that through an alpha-galactosidase enzyme test. For women, you have to have a gene test where you read through the genes to see what the change is causing Fabry disease in that particular woman. You can read through the gene, that's called sequencing. It's where you check the spelling of the gene. But sometimes that test misses a few changes, big changes that are like big additions or big deletions from that gene. And so we've got a secondary test that's important for women if we're trying to find out if they have Fabry disease that's called deletion duplication testing. You might sometimes hear it referred to as a microarray, or sometimes there's some other terms they'll use for it. But basically, it's a great big way of looking for big additions or subtractions from the gene. So if a woman has a misspelling in her gene or has a big piece missing or added, then that tells us that she has a change in the gene, and we need to figure out if it causes Fabry disease or not. If the mutation is found and it causes Fabry disease, or it's a variant of uncertain significance, then we need to look at a woman fully and understand how it's impacting her. Now, if someone in the family, a man, is at risk, then you can start with alpha-galactosidase A enzyme testing on blood, but then you want to do gene testing as well. And the reason for that is if you find an individual, male or female, with a gene mutation, then the rest of their family will most likely have that same gene mutation. Everyone in a family has the same change in their genes. There's going to be, of course, rare, unusual exceptions to that rule. But in general, if you know the mutation in a family, then you can test on saliva or blood or cheek cell swabs to find out if an individual has that same gene change that causes Fabry disease. So if a woman has a gene change that we determined is pathogenic, which means it causes Fabry disease, is a woman who doesn't have symptoms yet, does she have Fabry disease? If a woman who has symptoms, but we're not sure they're Fabry specific, is that Fabry disease? Is a woman for the first woman in her family who has that gene change, does she have Fabry disease? The answer is yes. All of those women have Fabry disease. If we think about them having normal plasma biomarkers, they still have Fabry disease if they've got a gene change that causes the disease. If they've got normal levels of enzyme alpha-galactosidase A, that's pretty common. That's about 30% of women who have Fabry disease. So these are a lot of myths that people think, well, I don't have Fabry disease for real. I'm just a carrier because I have one of these things. And I'm here to tell you that we have learned over time that these things are not as important. These are important for treatment plans. These are important for monitoring plans. But if you have a gene change that causes Fabry disease, we categorize women as having Fabry disease. And then we talk about what impact Fabry disease is happening on them and their health, but we don't say some are carriers and some are not carriers. Does that make sense? Mostly. Okay. The other thing that we've found recently from a few different studies, as well as some old studies, is that people with Fabry disease, women with Fabry disease, are not always so good at figuring out what is normal for them and what is Fabry disease that could actually be improved. So you may say, well, in my family, we don't sweat. And this is maybe before you've recognized that not sweating could be a problem for you. We could say, well, in my family, when we have fevers, we always have burning pain. And the answer is yes, but your average person does not have burning pain when they have a fever. And these are things that we'd like to help improve, because from my perspective, the whole purpose of identifying somebody with Fabry disease is then trying to improve the quality of life for them and then their family. So the way that we do this in women is we look at you from head to toe. You have to look at everything because, as I said, women can be complicated. They may have symptoms that are very silent because Fabry is a sneaky disease, or they can have very obvious symptoms, but the only way you can have a full picture of what's a good monitoring and treatment plan for a specific woman is to do a whole set of assessments. And then you have to do them again because Fabry disease gets worse over time. So even though a woman may today not have any problems with her heart, 5 years from now, she could be having problems with her heart. And what we want to do is catch any problems as soon as they can possibly be caught. So the reason for that is because we've got some great research out that says if you treat before there's progression to end organ damage, we hope that we can hold things steady. In young kids, we know that some of these things we can prevent from happening. In older folks, our goal is to stabilize the condition or prolong the health of a particular organ. And again, quality of life. We always want to have quality of life. These are the studies that came out, and you can see over time, they're really saying the same thing. Women who have a gene change in GLA gene that's considered pathogenic or causes disease, they have a huge impact on their lives. And that my favorite publication is one from 2007. This always makes me happy. Heterozygous Fabry women are not just carriers, but have a significant burden of disease and impaired quality of life. As a woman with Fabry disease, you might say to me, Dawn, yes, we already knew this. And I'm here to say yes, but we now have an article, and we have for a while now, that says it very clearly, very obviously, and tells us that most women with Fabry disease have symptoms. So I always love looking at the title of that one. But you can see there was an article around the same time that a wonderful student up in Cincinnati worked on, which was quality of life in Fabry disease, and found that women with Fabry disease, their quality of life is more like a woman with a chronic condition like multiple sclerosis than it is an average woman. And then that kind of all sums up in 2018 more recently, where it said, there were a lot of women who thought they didn't have symptoms, but when they really looked at them from head to toe, they did actually have symptoms. And about 30% of it was pain. Pain, hopefully something that we can try to address, try to improve, and again, improve quality of life by first recognizing that it's there. This is the other piece of information that really proves that women have Fabry disease and impacts their life significantly. It's kind of a weird graph, but I want you to think of it this way. What it's looking at is women and the length of their life and the number of times they have something significant happen, like a heart attack, a stroke, or kidney failure. And you can see from this weird downsloping set of lines that men with classic Fabry disease are most significantly affected and earliest affected, but women with classic Fabry disease are right there behind them. And in the next setup, women with non-classic Fabry disease, and then men with non-classic Fabry disease. The impact on life of Fabry disease, the most severe impact, so the renal failures, the heart attacks, the arrhythmias, the strokes, all these things happen more frequently in women of each of these different categories. So if when someone says, oh, women with classic Fabry disease are just like non-classic men, the answer is nope, they're not. Women with classic Fabry disease are different. Different from men with classic Fabry disease, but still maybe just as impacted. So I want you to say with me, Women with Fabry disease are not carriers. They have Fabry disease. And sometimes that's hard to wrap your head around if you are a woman who's always been told you're a carrier. But it's important to recognize that so that medical care can be given in the way that's going to be most helpful for you and give you the best quality of life. So why do all these myths stick around? Why does the medical community, why within the Fabry community, do we still hear about carriers? Do we still hear about these things? Well, there's some basic facts that can make it sound like that. So I mentioned that Fabry disease affects one of the X's, and most women only have one gene change on one of their X's. However, the funny thing about X chromosomes for women, so we've got 2 of them, but one of them turns off before we're even born. And it's supposed to be random. So you're supposed to have one X on about half the time and the other X on half the time. But depending on where one of those X's turned off, if it turned off that gene that functions, and makes enzyme is fairly normal, no, you cannot make a Twitter account. Having nothing to do with women. Women, you can make all the Twitter accounts you want, can't, but my 14-year-old cannot. So if you've got 2 X's.
There's someone being stupid in the Twitter comments.
Talking. You got 2 X's and one of those X's turns off, just leaving the X that has the gene change that causes Fabry disease. That means this X is not going to be making enough enzyme for whatever cell line is happening from that X. Conversely, if the X that has Fabry disease change on it turns off, then you've got this X still making lots of enzyme throughout the body. I like to think of it like this polka dots or like a calico cat. So a woman with Fabry disease may have not enough enzyme with some of the cells in her kidney because of the X turning off the way that it did. But her intestines, the way that her stomach empties, that may be okay. Or maybe she has less stomach problems because she's got enough enzyme throughout the cells there. But maybe in her kidneys, there's less cells that are impacted and have enough enzyme. So Fabry is X-linked. And so when geneticists first talked about X-linked conditions, they put them into 2 buckets. The buckets were recessive or dominant. Recessive X-linked condition means you've got one gene change and one X. A woman has another X and she should be just fine. There's not as many conditions that are X-linked recessive anymore because we find that women are having more symptoms. Originally, Fabry disease was considered X-linked recessive. Now we just call it X-linked. But the other option was X-linked dominant. And X-linked dominant is a way of talking about a pattern that genetic conditions run in families. But an X-linked dominant, usually, not always, but usually it means that it's so severe that the men who are born pass away really early, like maybe not even making it to be live-born children, or maybe passing away in the first years of life. So you can see how Fabry didn't quite fit in those 2 buckets, but of those 2, recessive made a little bit more sense, calling it X-linked recessive. However, over time, we learned that neither of these categories work. So we had to work our way around to just calling it X-linked, not recessive or dominant. And you guys probably know this inside and out, but when you're a woman with Fabry disease, you pass on that gene change that causes Fabry disease about 50% of the time. Gender doesn't matter. But if a man has Fabry disease, he only has one X, and he passes on to all of his daughters, because the way to make a daughter is to pass on an X, and none of his sons, because the only way to make a son is for a man to pass on his Y, and a Y has nothing to do with Fabry disease, so that's a whole other thing. So when we think about X-linked, we think about originally Fabry disease was kind of X-linked recessive because that's all we could really wrap our heads around for patterns of inheritance back in the day. But then over time, we've become more enlightened, and now we just say it's an X-linked trait, and we don't say recessive or dominant. The other reason that people thought that women maybe were carriers and not affected was that women with a genetic condition that has to do with an enzyme, there was a thought that if you've got a certain amount of enzyme and it's everywhere in your body, then you're going to be okay. And that's the whole theory of carriers of conditions that affect the enzymes. The thought was if you've got enough enzyme throughout your body, you shouldn't have the symptoms of that condition. However, because of the way that X's turn on and off, it doesn't really work in Fabry disease. So even though a woman could have normal enzyme levels in her blood, she could still have problems with her kidneys or her heart because we're not checking each of these organs to see if a woman has enough enzyme in each of those cells. So the reason that one of these mythologies hangs around is because originally we thought, oh, you got some enzyme, you should be fine. But then over time, we've learned that that's not the case. That's also why only about 65 to 70% of women will have lower enzyme levels because it just depends on what is produced in the body and then appears in the blood with the levels of enzyme. You could have great levels of enzyme in your blood and still have very significant Fabry disease. What's the final reason these myths consist? Why do people still think about Fabry disease as being carriers? Well, because it's still out there. There, in all the paper books, the people would reference, it's there. But now people turn to the internet. And if you Google Fabry disease in women, I'm afraid I found this just last week. It has carrier, carrier, carrier all over this. And I'm not going to call out the people who have it up on their website, but they're considered a Fabry Center of Excellence. Now, I did email them and tell them that this was up on their website still, and they were horrified and told me they'd fix it. But if you Google Fabry disease, sometimes you're going to end up with this. Not only does it say X-linked recessive, but it says carrier, 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 carrier all over it. It's sad. And someday I fantasize that I will just Google carrier and Fabry and then contact every single person and be like, guess what? You need to change this. And they'll do it. And then everything will be off the internet that's incorrect. But I think that's a pipe dream, I'm afraid. So I'll just go for the biggies. So I've already addressed this a little bit, but there was a school of thought for a little while that said women with Fabry disease should always be considered non-classic or later onset. So when we think about maybe like the past 10 years, we've been thinking about Fabry disease kind of on a spectrum, right? You could fall anywhere within here, but typically with classic Fabry disease, that means a man with classic Fabry disease has enzyme lower than 5% in his blood of the alpha-galactosidase enzyme, and they have symptoms in childhood. Women kind of fall in that same category. And then as you get into the non-classic area, we're talking about people who still have decreased quality of life, still have problems, but typically they don't have that onset in the first 10 years of life. And they may not have angiokeratomas. They may not have that burning neuropathic pain when they're younger. So that's kind of the two categories we put in. So it was not in anywhere reasonable to say that all women fit in that non-classic category, because we know from some great studies that women can have Fabry disease pain symptoms at age 7, at age 3. Women with Fabry disease and classic Fabry disease can have angiokeratoma starting in childhood. So not only that, but you remember this graph we just saw, this also proves that classic Fabry disease symptoms is not the same as being someone with non-classic Fabry disease. It's actually 4 separate categories: men with classic Fabry disease, women with classic Fabry disease, women with non-classic Fabry disease, and men with non-classic Fabry disease. Recognizing that spectrum means that there's people who fit in all the, like in the middle, who do things that are totally not from one side or the other. One of the other myths that we've run into is that girls with Fabry disease do not need treatment in childhood. If you treat them later, it'll be just fine. This can be different from center to center. This can be different from country to country. But what we have found, and there, Rob Hopkin, Dr. Rob from Cincinnati, did a study that shows that 41% of girls will have, I gotta move us over, 41% of women have neuropathic pain as their first symptom, with a median age, so that means in the middle of all counting them out, of 9 years of age. That means women are having symptom in childhood. And if you continue to have neuropathic pain, that burning pain, and don't treat it, then it becomes, the pathways of those nerves, that inflammation becomes a continued problem, and it's harder to fix it the longer it goes on. I also, I did a literature review study because I wanted to figure out a little bit more about early onset symptoms in children with Fabry disease, so under age 4. And there's at least 3 girls at age 3, 3, and 4 years of age who had onset of neuropathic pain. So we're talking about some women, not all women, having onset in childhood, and we need to keep an eye out for that. Again, head to toe, talking, looking, talking to the parents, and understanding for an individual woman when treatment should be done. This is the recommendation from the most recent paper. So if you look at treatment of women who have symptoms, asymptomatic women. So these are women who don't have symptoms when you first have it. You still would want to closely monitor them and watch for any symptoms with the plan to initiate treatment if there's evidence of any involvement, heart, kidney, CNS. So CNS also would count, in this case, we'd also be looking for neuropathic pain, but that's the wording that they'd use in the document. When we talk about women with Fabry disease, sometimes that's controversial as well. If a woman has classic Fabry disease and she has symptoms, then she should be started. That's kind of the end point from the recommendations from Ortiz et al. If it's a woman who doesn't have objective symptoms, like she's like, yeah, subjectively, I don't feel like I have burning pain. I don't really have GI problems. I'm doing okay. You should still do all the assessments that look for silent problems, protein in the urine. Someone will actually have a kidney biopsy, doing a brain MRI, doing a Holter monitor or or an EKG, looking at how a woman's heart beats, what the rhythm is. Because you can find evidence there that you may not have found that was there for us to see, just asking questions. And then later onset Fabry disease, also women with that or non-classic Fabry disease should also be treated. But it's important to first see if there's any evidence of symptoms that could be causing a problem. Again, recognizing that we want to start treatment before there's evidence of damage. So we want to start treatment not when there's left ventricle hypertrophy or enlarged bottom chamber of the heart, but before that. We want to get the best outcome that way. This is one that I run into a lot, which is the myth of pharma companies just don't care about women. That's why they don't put them in these early phase trials. And I'm here to tell you, it can feel like this, right? It can feel like, if you ever watch the Brady Bunch, Jan, the boys with Fabry disease get all the attention and girls with Fabry disease don't. And it can feel like that, and I understand that. But they have to start out getting the cleanest data. And the way to get the cleanest data in Fabry disease is work with classic males with Fabry disease. And the reason that's the cleanest data is because you can more accurately predict what's going to happen at different periods in life. Now, I would argue that at this point, where we have had treatment since 2003, this is going to be less easy. Men are not going to be as clean anymore, so we're going to have to look at things overall. But if you get nice, clean data that shows that something appears to be safe and appears to be preliminarily effective, that's when they can keep getting the money in order to go to a study that's a phase 2 or phase 3 where they can bring in women. So even though it can feel like sometimes women are being left behind, just remember that it's to everybody's advantage to get the best data possible so that things can move on. Because as you know, if a particular medication doesn't seem to be doing well in our population, they're going to stop developing it. And we haven't run into it as much in Fabry disease, but there's other conditions like MPS III, where the company just dumped the whole program, even though some people felt that was making a big difference for their children. The good news is that we've seen in almost every development of Fabry-specific primary medication that women are quickly included. So if we look at agalsidase beta and alpha studies, they did include females by the time they got to the late phase 2 or phase 3 studies. Migalastat, that's your Galafold, also included women, had their own separate women's studies in the beginning for phase 2, and then phase 3 were able to recruit as well. The penguin alpha-dase, from the very beginning of phase 3 studies, they included women, and phase 2 as well. You just had to have specific criteria to get in, and that was great because I feel that women were further in that process of development than later on. And then as we get into gene therapy, they're already planning for cohorts for women in gene therapy who meet certain criteria. So if you really are excited about doing one of these clinical trials or being involved in clinical research, they are going to get there. I don't want you to feel like you're never going to get there. So we'll get there. Okay, so what have we learned recently about Fabry disease? What's new? When I went to the meetings most recently, when I looked at the literature and did a search, what's some new stuff we've learned? Well, I'm here to tell you not enough, but here's what we know so far. One great thing is that I told you how sometimes you can have these cells in women's kidneys where you can have one cell that makes enough enzyme because of the way the X is turned off and the other one might. And we knew from some great work from Dr. Najafarian and Dr. Maurer, who are kidney doctors that are at University of Washington, that you can have a filtering kidney cell called a podocyte in your kidney that's right next to another filtering kidney cell, a podocyte, and they don't share. So one may have enough enzyme and enough lysosomes and be filtering and breaking things down nicely, and the other one's like, I don't have enough, can I borrow some? And the other cell's like, no, I don't want to share my enzyme with you. You got to just fill up with gunk until you die, which sounds like a really not neighborly thing to do. However, there's a recent study that was reported at World where they found that when they had some cells in a test tube, not really a test tube, but you know what I'm saying, sometimes these cells would share. They made these little, like, I don't know, I always think of them like, when you're at a bank and you get the vacuum tube. That's kind of what this looks like in my head. One podocyte would put out a little tube and send out some lysosomes who make enough enzyme to the other one. And so what they'd like to do is they found a gene they think that might make these tunneling nanotubes, these little vacuum tubes from one cell to another that helps them share. And they'd like to see if there's a way they could make human cells do it in human bodies. Now, we don't know. It's all very science fiction-y right now. But they did make cells that did it. So what if we could have all of our cells share, cells that we don't usually think of as being able to share enzyme and lysosomes that have enough enzyme? That would be a great way to treat particularly women. So that's kind of exciting. I was very privileged to be the person who got to present a poster at World that was about pregnancy and Fabry disease. So this is agalsidase beta. And what they looked at is real world outcomes. So women who were pregnant and who are alpha-galactosidase beta, Fabry disease, and how their pregnancies went. And when they looked at who was on enzyme and they followed them and they were reported, they found there was no increased problems for these women who are on Fabry disease. Their babies didn't have a pattern of problems that they'd expect to have. Like, when we talk about something that could cause problems in a baby, you'd look for problems during pregnancy that increased of a specific kind. You look for problems in the baby of a specific kind. And they didn't find any increased risk of birth defects or how babies did when they came out, or less live births, or problems with mama, none of that stuff. So that was just really good. Now remember, this is a small scale study, right? There was only 29 women in this case, but when they compared it against normal pregnancy complications, it looked just fine like everybody else. So that was just really nice to see, because previously we've just had like one case report of one lady over here, one case report of one lady over there, maybe some clinical experience. So this is kind of the biggest one they've put together. So we're gonna put together a publication, but for right now, this was just something that was presented at World. In case you guys don't know, World is this meeting that happens in February, and it's all about lysosomal storage diseases, and Fabry is one of those. So this is where we all get together and talk about Fabry and other related things. Linders, who does a lot of great work over in Europe in Fabry disease, they did this pretty cool study. Now, remember, small scale study, but Beano, you can take it when you feel like you're gassy. What they did is they said, okay, if we give people a bigger dose of what is in effect Beano, which is alpha-galactosidase A, does it help with some of the gastrointestinal symptoms like diarrhea, farting, and abdominal pain? So they took 7 people, 2 were women, 5 were men. So this is a good example of when women are in a study and men. And they gave them this higher dose of this oral medication. They took this pill, and they found that all patients had a decrease in the severity and how intense, so how painful the symptoms were. This was interesting because we always had the general theory, again, we're all about upsetting our general theories, was that the stomach acid would break down any pills we took of alpha-galactosidase A and it wouldn't get in the body. But there was actually one man who'd never had enzyme replacement therapy. When he started taking this, basically a Beano, at this dose, he did have a little bit more enzyme in his body. And all the men had a decrease in their biomarkers, that gunk that builds up the lyso-GL3 or GB3. So that was pretty interesting. Now, does it mean run out and take Beano? It does not. But it means that maybe we need to study this a little bit more and on a bigger scale. And maybe you could talk to your doctor if you're interested. Hey, do you think me trying out this over-the-counter medication for a certain amount of time because I have these specific gastrointestinal symptoms, could this be something useful to me? Might work, might not work. But if you're working together with your doctor, they can watch for any side effects that you don't want to be happening from this. And there were people on the study who were also on enzyme replacement therapy. So that kind of was looked at a little bit as well. So that was very interesting to me. And I liked that they tested women as well when they were doing the study. Okay, so this is one I want to reach out to you guys. And I want us to unmute and talk about what else. First of all, I've probably got some questions. I'll check the questions. And then I wanted to hear from you. What else do you think we need to study with women in Fabry disease? And what other myths have you run into that you think we need to do studies to kind of combat them? So I'm going to put the slides away and let's talk. All right, so let's look here. I've got one question here that I'm going to talk about while you guys are thinking about other things we should learn about in Fabry disease or questions that you have. The question is, I spoke earlier about early intervention, but I also spoke about watching and waiting for symptoms to go away. So for women who have symptoms, here at Emory, we recommend starting therapy. So we don't believe in watchful waiting for women who have symptoms. Now, if you've got a child who doesn't have symptoms, that's when you have to watch and check them out every year. So I may not have made that clear. Really, the goal is that if a woman has symptoms, we go ahead and start. Now, there are some women, and you probably have some of these ladies in your families, who just don't want to start therapy yet. And if a woman doesn't want to start therapy yet, we still want to take care of her. So then we'll continue to monitor, continue to wait, continue to get them what they need in the other times. But if a woman has symptoms of Fabry disease, that's a great time to start therapy. So that's one of those things that we need to keep an eye out for. You will find that in some centers, they do want to do more watchful waiting, even when women have some early symptoms. And sometimes they would like a kidney biopsy before they start therapy for women. And part of that is because they want to be able to prove to the insurance company why someone is on therapy. Because occasionally, for whatever reason, it can be a problem to keep insurance coverage for a woman if their biomarkers, their GL3s and their lyso-GL3s are not going down. I haven't had that problem, but I do know of a couple Fabry Centers of Excellence where they have had that problem where insurance tried to kick women off therapy because their biomarkers weren't going down. So insurance companies are not really savvy, but they try to put together like charts that are like, okay, if a woman has symptoms and her biomarkers are going down, then she should stay on therapy. It doesn't reflect the reality, but it's what we have to fight. So that's kind of what we're looking at there. I've got a comment here. I've read that Beano may not be good for people who are immunocompromised. I think there's a lot of things. That's why I say talk to your doctor first, because they may look at Beano and be like, nope, you shouldn't take this. Or they may look at it and say, well, this is what we're worried about, why we might want to look for this particular issue if you're taking Beano. And again, it's never a good idea to add a supplement to what you're taking without chatting with your doctor about how it might interact with medications you're taking. And if you're already on medications to help with your diarrhea or constipation, then you want to kind of consider whether or not you want to add to those things. So it's something you just want to keep an eye on, and always talk to your doctor before you try something new. That goes for any vitamins and supplements, because some of them are not great. I've got a question here talking about women who are pregnant and not on enzyme replacement therapy. So, yep.
Sorry,
No problem.
go ahead.
Okay, so let's talk about women who are pregnant and not on enzyme replacement therapy. When we talk about women on enzyme replacement therapy, all right, let's talk about our sister disease real quick. So we've got a sister disease called Gaucher disease, and Gaucher disease has storage kind of like Fabry disease, except it leads to things like low platelets. So during delivery, a woman who wasn't on enzyme replacement therapy during a pregnancy could have more bleeding than she should. So those women who have Gaucher disease were like, stay on your therapy. If you don't want to go off for first trimester, that's okay, but let's keep on going because we want to keep your platelets up real high so you do really well. In Fabry disease, we don't have anything easy to measure like that. And we don't have a real complication that we're like, if you get off therapy right now, then 3 months from now, we're really worried that you're going to have a hemorrhage during your delivery. Now, having said that, if you haven't been on enzyme replacement therapy in pregnancy, usually you don't want to change things during a pregnancy unless there's something that we're really worried about. Now, it says here that the protein in the urine is increasing, and that some women with just normal pregnancies will have increase in protein in their body as well. It does mean that that's something that you want to keep a nephrologist and a kidney doctor to keep an eye on. Particularly since when she's done being pregnant, she may want to take a medication like an ACE inhibitor or an ARB that reduces protein and get on enzyme replacement therapy together, because we've found from studies that those two things can really get rid of that protein if it's increasing. But every woman's a specific and special case. So even though that protein is increasing, that would be something where her baby doctor, her OB, should take a look and tell her if it's a worrisome level of increase, or it's just a sign that her kidneys definitely need some help as we move to the other side after she's done being pregnant. 34 weeks, you don't have too long to wait. But I just want to make sure that working with the doctors, they're not worried about blood pressure going up and having protein up, because those two things together can symbol another problem that has nothing to do with Fabry disease, but could make things a little bit worse. Let's see. Is this new oral pill prescription isn't expensive? Would it take other patients? So when I talk about Beano, Beano is an over-the-counter nutritional supplement. So it's not a medication like Fabrazyme or Galafold or substrate reduction therapy. It's not going to the point of the problem. It's not trying to to decrease the load of this in the whole body. So it would be something that we would talk about as an addition. It is not expensive. It is like you can buy a giant vat for like $90. It's available at Walmart. It's available at CVS. However, you don't want to take it till you talk to your doctor about it. And you want to understand what you're taking it for and what is it trying to solve. You don't want just to take it as something like a vitamin. You wouldn't do that. You'd want to make sure that you've understood what you're trying to solve with it, what problems you're trying to get rid of, and how you're trying to improve things. But it is definitely not expensive. It's been out for a long time. You can buy it at gas stations, by the counter. People have been taking it for a long time. Good. I'm glad that she doesn't have preeclampsia, Maddie. That's a big deal. Okay. Here's a good question. What if you tried all the treatments available and none of them work? What do we do to make sure the neuropathic pain doesn't cause too much damage? When we talk about trying all the treatments and none of them work, then the question is, which thing is not working? Is it not working because kidneys are getting worse or heart's getting worse? Is it not working because the pain's not getting worse? We find that sometimes pain is not improving with just enzyme replacement therapy or just Galafold or something else. So you end up trying medications plus. So enzyme replacement therapy plus Tegretol, enzyme replacement therapy plus amitriptyline. And you start adding things together. But there are times where you get to the point where we've decreased your pain, but we haven't gotten rid of it. We've tried all these things and it's not getting better. And that's where it's just frustrating. You feel like you're banging the head against the wall. But I think it's important to keep bringing it up. I think it's important to get a second opinion if you've worked with somebody like a neurologist and it didn't work out the way that you want it to. But I always think of it this way. I always have one key problem that I want to focus on the most at one particular appointment over the course of one particular year. And sometimes that's hard to do because you're intertwining all of these different problems together. Fabry is nothing if not affecting all parts of the body, except maybe the liver. That's a whole other thing. But the question is, what can you start improving with? What will improve your life the most if you focus on one particular thing? And a lot of times that is pain. And then you just have to work with somebody who's willing to try different things. And you have to be willing to be a little experimental, right? You gotta try this for 3 months and then wean off it. Well, that didn't work. Okay, let's try this other thing for 6 months and wean you off it. All right, that didn't work. And just seeing what the side effects are versus the pain that you're getting from and just trying things. And that's no fun. Nobody likes to try things that don't work. But usually we say okay, can we try it? Let's plan on trying these 3 things. Let's try these 3 medications and we'll try them in order. We'll try them this way. And let's see if they work. But you gotta be in close contact with me so I know if it's working or not, as opposed to just stopping it. Neuropathic pain and damage. When we talk about neuropathic pain, so we're talking about nerve pain, the damage that's done is that sometimes these neural networks get coded in and then there's inflammation and then it's hard to get the pain treated. It's not damaging other parts of your body necessarily, but it is something where you find that over time those nerves may not be able to sense the way they could. And that's where you get the numbness. That's where you get start having difficulty feeling the floor when you're walking if your nerves have got to the point where they're damaged. And the only thing you can do is work to find the medications that decrease the pain for you. And if you get to the point where you do have that numbness, the only time that I've seen numbness come back even a little bit is sometimes people, when they start enzyme replacement therapy, they have what's called the wakening. And we see this as the nerves that were damaged but not so damaged they couldn't come back. Some of them wake up a little bit. I'm not saying it completely cures them or you don't need other medications with it, but that's where I've seen some waking up. But the problem is wakening hurts. It hurts a lot because some people don't have pain anymore and then the wakening happens and they can feel things again and it's burning pain that they're feeling. So I think, again, it's just talking to your doctor and trying to figure out what's making sense for you and what's not. Okay, I wish I had all the answers there. But Okay, up we go a little bit. Facial changes in the research that's being done. So we did a study, one of my students did, her name is Lacey. She did a study on facial changes and differences in Fabry disease. So if you spent any time with guys with Fabry disease, you may notice that many men with Fabry disease look like they're related, like they're cousins, right? It's something about their nose and like the front of their forehead and something about the shape of their jaw. And that's referred to as the Fabry face sometimes, or Fabry facial features. It doesn't take away that they're all devastatingly handsome men, right? We're totally not saying that. We're just saying that sometimes they look more like each other than they do maybe their brothers who don't have Fabry disease sometimes. So there's a product out there that's a software called Face to Gene. And what it did is it analyzes all the little parts of the face and all these little data points and zones. And it says, can we look at these data points and figure out who has Fabry disease or what the changes of the face in Fabry disease, what does it look like? And do we have it in women? So Lacey did this study, and she looked at women with Fabry disease, men with Fabry disease, and people like average, what an average face would look like. And they did find that there is a difference in the measurements for men with Fabry disease. That means that if you take a picture of a man with classic Fabry disease, you're probably going to be able to identify it from the data points. So that was interesting. What she wanted to do was to see if men who were on treatment from an early age, did we see changes over time? But she didn't have enough people to enroll to really get statistical significance. But she did find that early treatment, so kids who started treatment like under 10, they couldn't be distinguished as having Fabry disease in some of the cases. Now, we only had like 5 boys, so we weren't able to make anything that said like, ooh, this is life-changing, this is different. But it was just very interesting. We saw a trend that said that when young boys were started on therapy, they were less likely to have that look that looks like their uncles, like their dads, like their other male relatives with Fabry disease. For whatever it's worth. And for women, they didn't really find anything like that they did in men. Women just didn't have that same measurements that looked the same when they looked at it. So we weren't able to find women. We couldn't just take a picture of a bunch of women and say, oh, this lady has Fabry disease and this one doesn't. So it just didn't pan out that way, which, kind of makes sense. I think, it doesn't have that same like look that you see with guys. All right, let's see. Someone took the Amicus pill and it really helped their stomach issues. Yay. But now she feels like the fart queen. All right. So yeah, at this point, it would be worth just chatting with your doctor or genetic counselor to see if that makes sense. Okay, let's see. Bino. Okay, yes. So with antibodies and GL3, good. Thank you for that clarification. All right, going back to the question about what if therapies are not working. And in this case, defining not working as a lot of antibodies keeping it from doing its job and the GL3 levels going up, 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 as opposed to down. All right, so different approaches people are taking. One is that some people have tried to do medications that knock the immune system down a bit. So some of these, we call them conditioning medications, and their job is to see if they can get the enzyme antibodies that are out there in the body to quit attaching themselves to the enzyme and keeping it from working, but instead to like calm itself down and see if we can get the enzyme to work better. So that's what some people are doing. They're trying these immune things. Now, it's not very common because we don't often have these neutralizing antibodies that are so bad that it's not working. But if your GL3s are consistently going up, 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 then that's where you might talk to your doctor about, is there anybody that we could talk to who might help with this? The other thing is that it's not FDA approved yet, but there is a medication called I can't say it, you guys. We called it Unigal. This is the product that's made by Protalix and then was marketed by Chiesi. I could say it yesterday. Pingunalcidase. Maybe it's a nighttime thing. Unigal. And its goal was to put a molecule on the enzyme. It's called pegylation. So they get like an enzyme like a Fabrazyme or a Repligal, but it's slightly different. And they put this molecule on it that tries to hide it like an invisibility cloak from the immune system. And their goal is to see if it causes less antibodies and causes less problems and stays in the body longer because it's pegylated, which is just the term for putting on this magic cloaking device. The data they've shared shows that it does seem to stay in the body longer. And they have different studies they have going on, some that look at every 4 weeks, some that look at every 2 weeks, some that are people from Fabrazyme who changed to Unigel. Some people went from Replagal, they changed to Unigel. And what they're finding is there does seem to be less of immune response for some of the individuals. Now, let's wait till it's FDA approved and we see the final data before we like hop on the bandwagon entirely. But just know that that's one of the other therapies that's coming down the road that people feel might help for individuals who are having it not work and their GL3 levels rising because of antibodies. Now, if damage has already been done to a particular organ, even if you get something that is not as recognized by the immune system and you don't have antibodies or neutralizing antibodies, it may not help as much as we would like it to, but at least that would help with the antibodies. Let's see, if a woman has a detectable bad gene, why not treat prior to symptoms? Cardiac at 57, yes. You're preaching to the choir. I would love it if we could take every woman who has a gene change in Fabry disease that we know could cause disease and give them a pill and they take it every day and then their Fabry symptoms are gone. The problem is if you've got a gene change that causes the Fabry disease, you have to prove it to the insurance company. And that's the big problem in the US, is that if you can't prove there's symptoms or evidence of problems or a pattern of problems or elevated biomarkers, sometimes you can't get enzyme covered.
Geez, how long is this?
Hour and a half. Sorry, child. When we think about looking at getting treatment, it's a battle. If you're on early, you heard that I had battled with an insurance company today for prior approval for Fabrazyme for a woman, and she has lots of symptoms. So it's a problem. And I think it's something that we are trying to get earlier and better biomarkers so that we're able to find something and say, look, here's an early sign. It's just going to get worse. It's not going to get better. And part of that is educating for us as experts, educating everybody else, all the primary care physicians, all the cardiologists, all the nephrologists, because treating people with without Fabry disease is very different than treating them with Fabry disease. So in some cases, they're like, oh, your rhythm is not great with your heart, but you know, it's not that bad yet. You're like, well, she has Fabry disease. It's just going to get worse. It's not going to get better. It's not going to improve. It's not going to stabilize. It's just going to get worse. So go ahead, and if you were going to thinking about putting a pacemaker in 2 years, why don't you try that now? But it's an education thing. And so it would have been wonderful to start symptoms before you find those cardiac issues. But we've got to fight with insurance to make it happen. And we also have to find that they have Fabry disease earlier. You know, we've gotten more and more referrals for ladies from eye doctors, and I love it because they're like, look, they've got the corneal whorls. I have just been in an educational session. I'm sending them to genetics and testing for Fabry disease. I'm like, yes, because a lot of time that's before heart disease. It's before kidney failure. It's an early state where we can start helping and maybe making a difference. So I'm always excited when somebody comes from an eye exam and they're young, like a young woman, 30s, 40s, you know, that's great for me. Then we can hopefully avoid some of the heart and other damages. Yeah, absolutely. The Fabry look. I like to think of it as distinguished look. It's a distinguished face look with Fabry disease. Why is there neuropathic pain? Yeah, so there's a lot of theories about why there's neuropathic pain. The two biggest ones are storage. So storage in the nerves, just like storage in the other cells lining our blood vessels, causes the neuropathic pain in Fabry disease. But the more recent one that seems to make more sense is it's storage plus the inflammation. So if you've got storage, your cell sends out a distress call. It's like, hey, I've got a problem over here. I can't work the way I want to work because I got all this gunk stored up in my lysosome. I don't like it. And the body says, oh, it's a problem. All right, we'll help you out. We'll make it like really irritating around their environment. Maybe that'll fix it. Because sometimes our body is just like, oh, I got a nail over here. I'm gonna hit it with a hammer. But it may work for, you know, getting rid of the flu, but it's not gonna work for Fabry disease. So it just becomes irritated. The inflammation could also cause issues with how the nerve's functioning. So storage and issues with the inflammation, both making your nerves not work the way they should. Let's see, when I was on Fabrazyme, I had to be in lots of pre-meds. Yes. Some women just skate on through with no problems at all. Some women, we got to slow the infusion way down. We got to do a lot. We got to do like pre-meds with steroids. And I wish we had a better handle on who we need to do that with ahead of time, because it's for men as well. I'd love it if they never had to have rigors. I would love it if they never had to have diarrhea after their infusion. But our only thing we can battle it with is slowing the infusion time and using pre-meds, steroids, Benadryl. But really, over time, we found that most people, after months, we can start tapering down those medications, so you don't have to take the pre-meds as much. But not everybody. But it's one of those things we don't give up on, though. We keep trying. We keep trying to give people the pre-meds so their infusions go smoothly, and then we try to taper off so you're not taking all these medications for a long time. And again, it leaves with people feeling a little bit like they're experimenting with, their health, but for a good cause. So if you're working together with your geneticist, with your doctor, with your genetic counselor, so that you all know what's going on. We're like, okay, today we're going to try without the 8-hour before steroid dose. Let's see how it goes. Today that worked out great, so let's try decreasing the 4-hour dose before your infusion. And that can really help if we're all working on it together and understanding. And then people are telling us like, oh, I'm still having symptoms. And we can hopefully help with that. All right, let's see here. Is there a list of doctors who believe women have Fabry disease? Oh, girl, I wish. It'd be kind of a rude list, though, right? I would say there are many doctors who believe women have Fabry disease. And I feel like sometimes one doctor with one woman would be great, and then the next time they see a different woman, just something they feel is different about that woman, and they don't treat them the same as the other woman. And I wish we had a better handle on that. But
Donna, I have a comment.
yes,
So if we're talking about women that are already, anyone who is already diagnosed, well, women, if you're talking about do they believe me, that's one thing. But I think that females that believe they have Fabry disease and aren't sure and are trying to convince a doctor to get them tested, you don't need to go through that. We have a definitive lab test. There's no point in speculating, and there are free testing available. So if you're in that category, please don't try to convince your doctor that you have Fabry disease. Get tested. And if you need to help getting tested, contact Dawn, contact me, and we can get you tested, and you don't have to speculate and wonder. Now, once you're tested and you test positive, you may run into the same problem. Some doctors may not believe everything you tell them, but that's a different problem. But you have to be tested. Thank you.
yeah, that's a very good point, Jerry. There's two different forks we're talking about. One is doctors who just are not as comfortable with genetic conditions and they don't want to test people. And they just read that women are carriers, so why would they test you anyway? Well, we've just disproved that myth, so we can ignore that part now. But there are different paths to get tested. There's free testing all over the place. You do need a doctor involved so they can get the results. But it doesn't have to be that doctor. You can have a different doctor who does that. And then when we talk about doctors for pain, neurologists are really the best doctors to help with pain, but you need somebody who focuses on neuropathic pain. So a lot of time you'll find them who specialize in diabetes. That's a great place to start, is look for, because they don't have no Fabry. That's okay. They just have to understand nerves and neuropathic pain. And Fabry is funny because if you ever have had carpal tunnel syndrome, they do that test where they zap you. And what they're looking for is the large fibers. So if you have neuropathic pain caused by carpal tunnel syndrome, that test is great. It's going to pick up all the large fiber problems you have with your nerves, but it's not going to detect the small fibers that are affected in Fabry disease. So pain from Fabry disease, unless they take a biopsy of your nerve, which people really don't do much, or they have a different test that's really rare, looking at small fibers as well as large fibers, they're not going to be able to quantitate your pain from Fabry disease. But you need a doctor who specializes in this nerve pain and who is willing to try different medications to treat it. And I've had actually some problems myself trying to find find doctors who like to specialize in that. We finally found one in our center, Dr. Harrison. He works in peripheral neuropathies. So that's, again, those burning pains in the hands and feet. And it's been very great because he has this like a flow sheet that's like, we're going to try this category, and that doesn't work, we're going to try that category, and this doesn't work, we're going to try that category. The problem is that he only works out of one facility, and it's hard to get patients in to see him. So we've been working with our doctors to follow that kind of algorithm without necessarily working with him as well. But again, we know Fabry, so our doctors are more comfortable with like, okay, usually, one of our doctors loves gabapentin, so we start with that. And if that doesn't work, then we go to carbazepine. If that doesn't work, then we'll try an SSR. But again, it's got to be a cooperative discussion because we're like, don't go cold turkey on this medication, please. It's going to cause pains other places. People do it, of course, and then they have like migraines, and we're like, don't cold
I have
turkey.
another comment.
Yes.
So the tests that many doctors do schedule you for are EMGs and nerve conduction studies. And those are the tests that won't do you much good because they're measuring large fibromyalgia. So you often come back normal, correct?
Yep.
And they're not helpful. So if their doctor suggests that, there are papers to show that physician that they're not really helpful, that they should be doing something else.
Yeah. The only thing I would say is that if they're looking for carpal tunnel and Fabry neuropathy, go ahead and do it.
Right, sure. Okay.
But because carpal tunnel syndrome is something that you can get a trigger release, it's a pretty common, done a lot because we all use computers now and we don't have good posture. That is something they can work on and fix. So working on the Fabry part is going to be harder. And if you've got carpal tunnel syndrome and Fabry related pain, they can at least fix one of those things and we can work on the last one. So
Great. Thank
the
you.
reason that you might get a nerve conduction test or an NCV. Okay, let's see. I was on Fabrazyme, and we already talked about that. 3 daughters in therapy, 6, that's great. Yeah, I mean, we work really hard to get our ladies on therapy. It means lots of insurance time, lots of, double checking and maybe getting different studies. So our ladies have to be patient with us sometimes, but on the whole, we've been able to get almost everybody we need on therapy. I no longer have burning pain in my feet and hands, but I have pain all over my body. Like every cell of my body hurts. What can I do to ease it? We'd have to understand more about why, if someone's having burning pain all over their body, if every cell that feels like it hurts, that's more of an aching instead of a burning, maybe. That would be, so when we talk about enzyme replacement therapy, if you have Fabry disease, we like to do trials of enzyme replacement therapy just to see if it could help with that pain. But the trial would be something like 6 months because that's how long it seems to take to really start dampening pain more down. Some people say 3 months, but I think the biggest change you see is over the course of 12 months. But that may be in combination with another medication that maybe a neurologist could work with you on. Pain all over the body can be a lot of different things. It could be fatigue, it could be, it could be nerve pain, but it just depends on what kind of pain. And I think that's one thing we need to study more in Fabry disease is the different types of pain. Because there's pain crisis, which is all over your body, but not all the time, not every day. It's usually when you have a fever or if you've overexerted yourself. There's that burning pain in the hands and feet. There's kind of aching joint pain that could be from that same nerve pain, but just focused on the joints. And there's these more unusual ones. Like I have some women who describe it feels like a knife being shoved in the bottom of their foot. I hear about that a lot. And then full body pain, fatigue, I hear more about that, aching pain. And enzyme can help with that, but you don't know till you try. So that's one of those things where it's like you want to rule out other causes for full body pain as well. You'd hate to miss like a arthritis or rheumatoid arthritis or something that we could really do more for because we're just looking at Fabry causes. But it's definitely worth checking out. All right, let's see. How do you feel about newborn screening? Oh, good question. So I would love for everybody to get diagnosed early, so then we could treat them early, and then maybe we could change a lot of symptoms and make people's lives a lot better. And if you do newborn screening, you can detect not only them, but maybe a sibling and maybe a parent. Now, I would love to do it maybe at age 3, but there's no way to do that. You can't consistently test everybody in the United States any other time in their life other than newborn screening. So I feel like newborn screening is our best hope for early diagnosis, but it's got a couple hiccups. It's got, some mutations that we recognize are controversial, and we're trying to figure out if the gene changes cause symptoms or not. It can cause a lot of worry for parents for a condition where maybe they won't need treatment if it's a later onset mutation. They won't need treatment until they're in early adulthood maybe. But I don't think not knowing the answers is a good enough reason not to test. if that makes sense. So I support newborn screening for Fabry disease, but I am not convinced that the recommended uniform screening panel is going to have it on there anytime soon. That's the panel that is recommended across the United States, but every state gets to pick on their own. If I could have newborn screening for Fabry in Georgia, I would jump at the chance. I think it would make a big difference in a lot of people's lives for the good. And I think there's been enough studies done, at least in some of these other later onset conditions, later being after newborn period, where it makes a difference. I just think that it doesn't follow the traditional requirements that newborn screening requires to test for everybody in the United States. So it's going to have to be on a state-by-state basis. One of the things that's happened that can be very useful for getting Fabry testing is that Perkin-Elmer has a kit that basically it's got these substrates, things that you need to test for newborns. And Fabry is bundled in with Pompe, MPS, Krabbe, our cousin diseases that are lysosomal. And if they're testing for our cousin diseases, sometimes they just lump Fabry on in there and test for that too. So that would be what happened in Illinois. That's what happened in Missouri. They didn't purposely say, like, we want to test for Fabry disease. They said, we're testing for these things and we can test for this too. Let's do it. And that's kind of what happened with a different set of diseases called fatty acid oxidation diseases. We now test for some conditions that we would not usually test for because the test was available and we could do it. So that's what happens with Fabry disease. But I think that every state's going to do something a little bit different. They do right now, and they're always going to do it a little different. And we'll just have to see what happens over time. But yes, if somebody said, Dawn, would you like to go speak to the RUSP about why Fabry disease is important? I would say yes, I'd be delighted to join you in that endeavor. Recognizing that you're probably going to tell us no. But I am fine talking about it and being part of it. I wish I could be more optimistic about whether or not the panel that decides on these things would say yes. And it's not because it's not an important disease. They totally recognize that. And it's not because early therapy isn't useful. They recognize that. It's just that newborn screening often says if it's not something that has to be detected in the first weeks of life, then we're not going to necessarily add it to this panel. Fair, not fair? I don't know. It's controversial, right? Anybody like me, or I'm the only person who feels like they've gotten worse. I would hope I'd feel better. Yes. The thing about Fabry disease is that it still progresses, and I feel like there are points where women start therapy a little bit later and things still progress. Like the heart still gets worse, even with therapy. The kidney still gets worse, even with therapy. But what I've seen in the data and what I've seen from my patients is that it's much slower than it would have been without therapy. Does it fix everything? It does not. But if we can protect somebody's kidneys and then treat their heart, or if we can, keep the heart from getting more enlarged and we have to replace kidneys, it's okay, right? But we really need to understand better what's happening in people who've been treated. If you've been on enzyme replacement therapy since 2003, 2004, we have to understand what that means for your health as you get older. I'm afraid that, the treatments we have don't fix everything. And so we have to understand what that means for women who started therapy when it came out. So I think that you're not alone in that. I think there's lots of women who feel like, I've been on therapy, why am I not fixed? And the answer is hopefully that you're doing a lot better than you would have been without it. And you're kind of the trailblazers. You're the one that we're learning from. And you're the one who's proving that, yes, we should have started therapy on the earlier questioner's wife who, maybe when she had her first sign of heart disease instead of waiting or getting him diagnosed. Let's see. My husband's just diagnosed. Oh, how many women have gotten surgery because they feel fat? It's kind of a random question. But does anybody who's had gastric bypass or surgery because your weight gain has been causing a problem that caused more problems for your heart as well as having Fabry disease? Anybody who has had that happen so far? Yeah, I know that I think we've got one lady who I know of has had gastric bypass within our group. And she got it because she was having a lot more pulmonary function issues. and it was putting more strain on her heart. And so when she had gastric bypass, it decreased the other things that were making her health worse, and it's made a big difference in her quality of life. So the biggest question is, has a doctor looked at your heart and said, okay, gastric bypass might be an option for you, but again, it's not going to solve everything. We just have to make sure that it's done in a safe way and that you're getting rid of issues that are related to having more weight and having, maybe having more liver problems as opposed to necessarily helping the Fabry specifically. Although anything that decreases your risk for heart problems is going to be a benefit also to having Fabry disease. Okay, my husband just diagnosed. I'm taking my 9-year-old for testing tomorrow. We know what her levels are. Any questions I should ask? I think when you've got a 9-year-old daughter, the first thing you should ask is, are we going to draw blood to look at her kidney functions? Are we looking at her heart? Are we going to do an EKG? Are we going to do an echo? Should we do a baseline MRI? The first thing you want to do, though, is make sure that they go ahead and confirm that she has the gene change your husband has. Not because inheritance pattern we'd expect it to be any different, but you'll need that report before you have somebody on therapy, because you have to send over the report that shows that she specifically has that gene change. Again, any men with Fabry disease, when they pass on their X chromosome, then they're passing on Fabry disease, but there's been weird exceptions, right? So the insurance is like, wait, prove to me in this child that you have Fabry disease. So I think the biggest thing is, just understanding like, hey, we ask all these questions about how she's feeling right now. What monitoring are we going to do every year? How often do you want to see her? What do you want to start therapy now? If not starting therapy now, what are the things that together would tell us that it's time to start therapy? So just kind of understanding a little bit better from your doctor what they plan to do for therapy. Because everybody's got a different approach to it. So you want to know, what's our plan together for monitoring the Fabry disease and deciding when it's time to do therapy. So that would be the big things. And the other questions you just want to ask is, how are we doing the testing? What testing are you doing? Because you want to check the enzyme levels just as a point of curiosity. But in order to really confirm the diagnosis, you've got to do that gene test where you read through the gene, look for misspellings. You could just look for the same gene genes your husband has, but sometimes they want to read through the whole thing. And it's at this point through the testing programs, it's free either way. So sometimes it's nice just to take a full gene look. Medical marijuana for pain. Yes, yes, yes. It seems to make a big difference. If you can do it legally in your state, please do. I've seen that for gastrointestinal issues. I've seen it for help for nausea. I've seen it help for pain. Keep in mind, though, if you work for a company that does drug testing, they will find medical marijuana in there, and you have to go through the whole rigmarole of proving that you're taking it for medical reasons. If you're taking a state where it's illegal to take it, then you risk that particular running into know what your laws are there. But for real, medical marijuana, not necessarily smoked. You can edibles, you can eat it. Some people do marijuana light, which is CBD oil, gummies, or brownies. It can make a difference. But again, check in with your doctor. Make sure that when you're using marijuana, it's not anything that counteracts what you're already taking. Because there's some medications that work in a similar pathway as the active ingredient marijuana. And you want to know where you're getting it from, because there's different varieties of marijuana. And some of them are really strong. And some of them are focused on pain and trying to help you with medical parts. And some of them are focused on getting you feeling funky. So you want to have high levels of helping with pain or gastrointestinal and low levels of funky so you can just function, right? Because you want to be able to do all your daily activities. And I would say that I have a lot of patients who smoke marijuana, and it's not, medical marijuana is not something we can prescribe here in Georgia. But CBD oil is fine in Georgia. But there are specific indications you can try, and we just say just that. If we're in California, we'd prescribe this for you. We're not in California. Just let us know if you're what you're using. When we talk about smoking marijuana joints, then we start worrying about the impact on your lungs. So we prefer you to get it different ways, and you just want to make sure you have doses that are good for you. And there's dispensaries and people who will tell you all day long about the different varieties and how much they have and things. But I am not an expert in those by any means. All right. I am 74. I have not been able to get pain meds despite being well documented. I did get relief by taking dimethylglycine, which is supposed to help with synthesis lactic acid. Okay. Yeah, I mean, if it's helping and your doctor's cool with it, then I am all for anything that's going to help you and is not illegal to take, which dimethylglycine doesn't seem like it would be anything illegal. Um, I have patients who take supplements that we've vetted and feel are okay, and they get real relief from it. I have people who really enjoy floating tanks. I don't know if anybody has tried a floating tank. It's the sensory deprivation where you go in and you float in water. And we actually did a poster. I did a poster with a lady who has Fabry disease, and because she really found it made a big difference. So try things. You know, there are alternative routes to getting some pain relief that may be useful after you've tried out enzyme replacement therapy and or the treatment, primary treatment, and some of the things like carbazepine or things that might be useful. It's just the side effects sometimes of those medications can be too much for certain people. So, work with your doctor to think about some alternatives. Does Fabry cause severe sacroiliac itis and arthritis in the hands and feet? We have not found any relationship between arthritis and Fabry disease itself. Now, there can be some joint pain, like knee pain, that we see in Fabry disease that's called neuropathic arthrogryposis sometimes, but it was just a fancy way of saying the nerves in the joints are also affected. But when you have arthritis, usually they'll see nodes, they'll see changes in the bone and the joints, and that's not associated with Fabry disease as far as we can tell so far. We need to keep an eye on the joints, though. I think there's more work to be done in joints in Fabry. Trying to get newborn screening added to Alabama. Cool. Working with your doctor. Yay, Eric. I know, he's very excited about it. So I always say, I support newborn screening. I'm excited that they're trying to do it in Alabama. We talked about it. Dr. Wallace and I have talked about it several times. And I wish you guys all the luck. Because, statewide, you have a much better chance, particularly if you've got a senator or legislator on your side, plus a doctor who can explain it. You just have to make sure the state lab has a way of testing. And Alabama, I think that they're gearing up for maybe Pompeii and MPS, which means they could do it as part of that panel. So yeah, do the good fight. Let me know if I can help. I'm excited to see what happens. Again, sometimes it can be helpful to hook Fabry to other diseases that do present in the first weeks of life, like Krabbe or Pompeii and MPS. You might check and just see from the newborn screening perspective if they've already approved things like that. Because then you might have a better argument for saying, I see you've approved these conditions. Well, there's a test where you can do all of these, and then you can follow this path for approval. Let's see, we're getting late, Jerry. Do you want to go ahead and do your announcements? I've got so many good questions. So let's see. I can do real quick on some of these. White matter lesions, some of them are related to normal aging. Sometimes they're related to vascular disease. And sometimes, go ahead, Jerry.
Okay, great. Well, thank you for a great presentation and so many good questions and answers. That was really appreciated. Thank you once again. So the next thing I'd like to do is just show you a few announcements. Let me pull this up on my screen. And let me share my screen. Can everyone see that? Dawn, can you see the screen? Okay.
Sure can.
So each meeting we do a few announcements for you. And the first slide is one of our jobs is to make sure that we keep the community informed about what's going on with clinical trials and the initiatives of the industry partners of what they're doing. So it's one slide that you can either take a photo of, or you can wait until that we send the recording out. Will just be a few days to look at it in more detail. But it basically tells you what's important, what one of the things or a couple of the things that are important to each of our industry partners and what they're doing to keep you updated. So the first one are Sanofi Genzyme and Amicus, who are just want to make sure everyone has the websites available that that you can find more information about them. And Casey, of course, most of you know that they were not approved on April 27th as we thought they might, but we're awaiting more information on what happens next. And if you're not part of, if you haven't joined Rethink Fabry, you can keep up to date that way also. The Casey's website, Avrobio, Sangamo, 4DMT at the bottom, and now there's a new bullet there for Freeline, who gives you a website, and this one's not on our website yet, which I'll show you in a moment, but here's information you can start learning about Freeline, who's also doing a gene therapy program. And then, of course, back to Idorsia. Idorsia, who's doing the substrate reduction program, has closed their clinical trials, or actually closed recruitment, but are on the path to finish gathering all the data and submit their application to the FDA for approval when the time is right. So this is something I'll show you where to find, you can find this slide and the recording when we put the recording on the website in the archives and recordings tab on the registration website. The next thing I'm going to show you is where to go for additional information about all of the organizations I just talked about. And most of you have seen it. So if you go onto our home page, and you'll see on the top menu bar, company and clinic information, select pharma, clinic, or support organization data or info, and then you'll see what it produces when you do that. So you'll see in the pharma section, you'll see the different industry companies, and if you click the read more link, then all the resources they'd like you to know about. So Freeline's resources aren't up there yet, but they will be soon. And you can click each one and get the latest and greatest from each organization. Clinical trial websites and various resources that each one provides. So the next slide I have, if I can make it go, hang on. This happens to me every time. It stops working and I have to restart it. Oh, there we go. So we're still giving out calendars. So if you haven't gotten a calendar, we're sending out messages also. And everyone that attends the meeting, just email me your current address so we can make sure we have the right one on file, and we'll send your calendar to you if we haven't done it already. And here's the next. So if you go back to the registration website where you signed up, as soon as we're finished tomorrow, we'll ask Brenda and then our contractor to disable the link to register for this meeting and enable the next link, which is May 25th with Dr. Hopkin talking about edema. So you can keep tabs on the registration website for all of the above, for the schedule, for the speakers and bios, and for our sponsors, and the archives and recordings tab. So that's all available to you. The next thing we're going to do is I'm going to stop sharing my screen. And we're going to pass it back to Dawn and Brenda. So as you know, each time we have a prize drawing. This portion of the meeting is only for the individuals with Fabry, their family members, and caregivers. So what's the secret word won't be secret anymore. What's the word for today?
The word for today is actually a phrase. It's women are not carriers. So to be entered in the drawing, type into the chat, women are not carriers, and that Brenda will put it in the drawing.
Into the chat box. Thank you. We'll give you all a minute to enter your answers, and then Brenda will take that. We use a random number generator, so she'll assign a number to each of your names for all of the entries. Then she'll put it into a random number generator and tell us who the winner is. So if you'll just hang on for just a second, we'll be right with you.
In the meantime, I'll just thank you guys for listening to me. I usually, when we do ladies sessions, I like to just hear from you guys so I can learn from you. This time it was mostly like the Dawn talking. I appreciate all your really good questions, and I love that you guys chipped in and gave me more information in the chat as we went. So thank you guys for all your attention.
And I've never attended a ladies' meeting, so this was a first for me.
Yeah, Jerry, usually you're running around like a chicken with your head cut off. You don't get to hang out with us ladies. Those are
Always. Yeah.
important things.
Well, thank you, Dawn. That was good.
Anytime. Thanks for joining.
But I do resemble that chicken once in a while, most of the time.
That's because you're doing important stuff. Run around doing important stuff.
Well, thank you. Oh, and just a little bit more trivia while we're waiting for Brenda, is I just had about my 12th heart biopsy and still no rejection. And so the clinic said that if I haven't had any rejection by this time, just over 7 months from my transplant, that I'm not likely, not impossible, but I'm not likely to have any rejection that has any significant effect. So that's all good news. Yeah.
Wonderful news. Good job, Jerry.
Thank you. Yeah.
Love it. Go, heart, go, go.
And I really didn't have to do anything. I just had to lay there, and everybody else did all the work.
I don't know, Jerry. I think you did a lot from that hospital bed.
All right.
So I had a question about sharing information about the women's meetings. So we do women's meetings in non-COVID about once a year in April. And sometimes we get scholarships to bring people down to join us, usually one or two. But we also have our ladies meetings at the Fabry Support and Information Group annual meetings. We usually have a ladies meeting, a breakout session. And I don't think we've done one. Sometimes we end up having ladies sessions at the NFDF annual meeting, but they're not as formalized.
Yes. We haven't put the agenda together yet, but we will soon.
There you go. I'm excited. I've missed it. Okay, we have the winner. The winner is Beth Kelly. So Beth, you won a gift card and you'll get it sent to you. So
Yeah, so Beth will send you a gift card, Amazon gift card. Congratulations. And with that, thank you, Dawn. Thank you, everyone, for participating. We're only 3 minutes over time, and it was a great meeting, I thought. Thank you all so much.
great. Thanks, everybody.
Thank
Thank you, Brenda.
Bye.
Bye.
Thank you. Hey, see you in a couple weeks.
See ya.